Good evening, ladies and gentlemen, and welcome to the 2013 MS Research Webinar. Your host for this evening is Dr. Karen Lee, Vice President of Research and Managing Director of the End MS Research and Training Network at the MS Society of Canada. Dr. Lee, your line is open. Please go ahead.
Thank you. Good evening, everyone, and thank you for joining us. For those of you who are joining us via the web and who are able to see us, hello. This month, the MS Society of Canada launched One Day in May, a campaign to raise awareness on multiple sclerosis and the lives of Canadians impacted by the disease. Tonight we are capping off One Day in May with the webinar, which will provide you with a comprehensive overview of the exciting MS research that is happening here today. Joining us tonight are a panel of leading Canadian scientific and clinical MS experts who will present and answer questions pertaining to therapy, cause and risk factors, nerve damage, myelin repair, symptom management, quality of life, and other related topics. On behalf of the MS Society, I would like to extend a warm welcome to Dr. Amit Barar, Dr. Ruth Ann Marrie, Dr. Anthony Feinstein, and Dr. Jack Antel. Dr. Antel will be presenting in place of Dr. Paul O'Connor, who unfortunately cannot be here with us this evening. Each panelist will present a brief overview of their research and take a few pre-submitted questions before we open the line to take questions from callers. You can also submit your questions through Facebook at facebook.com/MS Society Canada, or you can do it by Twitter at MS Society Canada. After the presentation, callers will have the opportunity to direct their questions to anyone on the panel. Since we have only allocated 2 hours for the webinar, we do apologize in advance if we're unable to answer all of your questions. So since 1948, the MS Society of Canada has invested over $140 million for MS research, and we continue to support breakthrough science both locally and around the world. With people who live with MS at the center of our work, we're committed to funding research that will lead to the development of accurate imaging methods for better detection of lesions in the brain, advancement in treatments for managing physical and cognitive symptoms, and a more in-depth understanding of the mechanism of MS, the disease. Each year, the MS Society of Canada approximately funds $10 million into MS research, which goes to support innovation and excellence in areas of top research priority. We proudly support researchers in training during various stages of their academic and clinical careers. Through this commitment, the MS Society fosters an exceptional community of Canadian researchers and has become a leader in advancing knowledge and treatment of multiple sclerosis. Now, let me take the opportunity to introduce our first webinar presenter. Her work is an example of the success that the MS Society of Canada has seen through its research program. Dr. Ruth Ann Marrie currently holds the Dr. Donald Patey Career Development Award from the MS Society and has played an important role in advancing knowledge in population health patterns in multiple sclerosis. Currently, she serves as the director of the MS Clinic and is the Associate Professor of Internal Medicine at Community Health Sciences at the University of Manitoba. Dr. Marrie closely observes the onset of the mental, physical, and biological conditions which may arise in MS patients, a phenomenon known as comorbidity, while in the hospital. Her work in this area, funded through the MS Society, will lead to effective treatment of comorbid conditions in hospitalized MS patients, leading to more effective disease management and improved health outcomes. Dr. Marrie is also a co-investigator on a Canadian collaborative study funded through the Multiple Sclerosis Scientific Research Foundation. This study is led by Dr. Brenda Banwell, and it looks at children with MS and other demyelinating disorders. Looking at the childhood population with MS may provide us with critical information for the adult MS population. Please welcome Dr. Marrie, and thank you, Dr. Marrie, for being here with us this evening.
Hello, good evening, everyone. It's a pleasure to talk to you this evening. So, as Dr. Lee indicated, one of the areas that I work on is comorbidity or coexisting health conditions in MS. And so I will share a little bit of what I've been working on with regard to that area. So before we get started, we should make sure we're all on the same page as to what comorbidity is. So when we're talking about it from a research or a clinical standpoint, we're saying that it's looking at the total burden of illnesses that a person has other than the disease we're studying. So in this case, if we're looking at a person with multiple sclerosis, if they have diabetes, that's a comorbidity. If they have high blood pressure or fibromyalgia, those would be all comorbid or coexisting conditions. Having more than one health condition is pretty common in the general population, and that increases with age. And when we've looked in other diseases, I became interested because in all of the other chronic diseases, if you looked at a comorbid condition, people who had more than one condition were more likely to have lower quality of life and more problems with physical disability. And so I asked the question of what is the case in multiple sclerosis and what we might learn by focusing on that. So one of the key issues is that I frequently get asked in clinic, what the course of my disease will be or how much disability might accumulate, and we're not very good at predicting that for the individual patient. And some of that might be explained by differences in coexisting health conditions, so that might help us to understand things better for individual patients in the future. It might also help us to tailor treatment around the other health conditions that the individual has. I also think it's potentially helpful if we understand that people with diabetes have more of a particular kind of symptom or the disease progresses more rapidly, for example, then maybe treating that condition, the diabetes, more aggressively might help with multiple sclerosis. So these are some of the reasons that I became interested in this area. So before we can understand how the coexisting health conditions impact MS, we need to actually know what conditions are most common and what ages they occur at. Is it the same in men and women? Is it the same as other people in the general population? So we thought we'd start basically at the beginning. And so the beginning is to figure out how we can learn about that information. So some of the work that I have been doing, funded by the MS Society of Canada, is to use health claims data in order to figure this out. So every time you see a healthcare provider, a doctor, an optometrist, you go to the hospital, you get an MRI, there's a claim that's generated that goes to the province, and that's how they track healthcare, and it's tied to a diagnosis code. And that covers most of the population in every province. So we've been working on some ways to use these data in an anonymous way to study comorbidity in multiple sclerosis. So in looking in Manitoba, where I am based, we looked at the most common comorbidities in people with MS in 2005. At the top of the list, you'll see that depression affected about a third of individuals over their lifetime. So that's quite high, but consistent with what's been reported elsewhere. And then there's some other conditions that are common on the list. So high blood pressure, you'll see affects about 20%, migraine headaches, about 20%, lung problems like asthma or emphysema, as well as irritable bowel syndrome were also common. You'll also see on the list high cholesterol, cataracts, thyroid problems, and diabetes. There are other conditions, but these were among the most common. So we decided to then compare those to what occurs in the general population. So we used the claims data to find some individuals of the same age and same sex as people with multiple sclerosis living in the same parts of the province to do our comparisons. So in the top panel, you can see are the people with multiple sclerosis, and in the bottom panel, the members of the general population. And you'll see a couple of clear patterns. So in both groups, as you get older, most of the health conditions increase in frequency, which is what we expected, except for migraines. So thankfully, for those of you who suffer with them, they do become less common as you get older. But the couple striking patterns are seizures were more common in people with multiple sclerosis, irritable bowel syndrome more common than in the general population, inflammatory bowel disease slightly more common, and migraines also more common. So there are some differences in the conditions that people with multiple sclerosis experience as compared to people who don't. So our next step was really to begin looking at what the impact is of comorbidity. So I only have time to talk about a very small aspect of that, but one of the things that we've been doing is we asked a group of slightly over 900 Canadians with MS from British Columbia, Alberta, Manitoba, Nova Scotia, to participate in a study where we could ask them about their quality of life over a period of 2 years and to see how that was related to the other health conditions that they had. So in this group of individuals, slightly over a quarter of people had at least one comorbidity, but 17% had 2, 11% had 3, and almost 10% had 4 or more. So some people had really several. We got an average number for their health-related quality of life using a scale we call the Health Utilities Index, or the HUI. And we noticed, as you'll see in this graph, that as the number of conditions here on the bottom increased, that the quality of life as measured by the HUI decreased pretty steadily. This little bump here where it levels off is probably because we don't have very many people in this category. Once we noticed that the quality of life declined with increasing number of conditions, we asked the question of whether there were specific conditions that were more likely to be associated with lower quality of life. And so fibromyalgia and migraine, both of which are associated with pain and to some extent fatigue, had a big impact. And then depression and anxiety also had a substantial impact in terms of reducing quality of life. So we're continuing to look at that. And so at this stage, what we can say in terms of the work that we've done is that coexisting health conditions are very common and that they increase with age, that epilepsy, migraines, fibromyalgia, the irritable bowel syndrome, and inflammatory bowel disease are more common in MS than in the general population, that comorbidity reduces quality of life in MS, and so this gives us the potential target of working on those other comorbid conditions to improve quality of life. And we think that there are enough findings here that we need to continue looking further to understand why it is that the comorbid conditions influence quality of life and to begin looking at other questions like how it might impact relapses, ability progression, and responses to treatment. And so with that, I am happy to take any questions.
Thank you, Dr. Marrie. That was an excellent overview. And I'd now like to ask you a few pre-submitted questions pertaining to your research. Now, during this time, I'll ask any callers who have questions for Dr. Marrie to enter the queue now. Operator, can you give us instructions on how our callers can line up to ask their questions?
Yes, thank you. Ladies and gentlemen, if you do have questions, please press *1 on your touch-tone phone. Once again, that is *1. You will be queued for questions, and then your calls will be answered in turn. You may press *1 at any time.
Great, thank you. The first pre-submitted question is, does comorbidity with depression compromise the kinds of medication available for MS?
That's a very good question. So depression, as we talked about, is very common, and so it is worth considering when one is evaluating treatment options for people with multiple sclerosis. So we can think of several possible medications in people with MS. So with the disease-modifying therapies, there was some initial concern with medications like beta-seron and Rebif and Avonex, so the interferon betas, that there might be an increased risk of depression in individuals treated with those medications. But over time, we've become aware that that is not a substantial issue for most individuals. So for the average person with depression, I usually discuss this, but it doesn't prevent me from offering that medication. And those kinds of issues haven't been a concern for the other disease-modifying therapies. Whenever you're thinking about symptom management, there are a number of other medications that we might use, and many of them do have the potential to affect mood, some in a positive way and some in a negative way. So it's always worth reviewing whether an individual, how severe their depression is, and all the medications we're putting together just to make sure we're not contributing to depression symptoms with all the medications that we're using. But in general, we have a lot of options, even if you do have depression, to manage your symptoms and your overall disease.
Great. Thank you. Now, are there any callers that have questions for Dr. Marrie?
Yes, we do have 2 callers. Would you like to take those now?
Sure, and I do ask that the callers make the question not specific to themselves, but if they can provide a more general question, that would be most appreciated. So caller 1.
Thank you. The first question is from Susan from Toronto. Susan, your line is open. Please go ahead.
Yes, hello, doctor. My question is for fibromyalgia that you spoke about, certain people that are dealing with MS that also have other conditions as well. And I deal with fibromyalgia, and I was wondering what you look for patients that are dealing with fibromyalgia, because I haven't been clinically diagnosed with fibromyalgia, but I do believe that I have it because I have spots all over my body, right? So I believe it to be true. And recently I went for a physiotherapy treatment using a TENS machine. Yes.
Susan, sorry, may I ask you to keep it to one question? And your question is related to fibromyalgia and its relation to multiple sclerosis?
Yes.
Dr. Marrie?
So in general terms, some of our work, and there hasn't been a lot of work on fibromyalgia and MS, suggests that it may be more common. But it's important to have an individual who's an expert involved in making that diagnosis, so that may be a rheumatologist or a physiatrist, to try and sort out whether it's really fibromyalgia or whether it's pain, so neuropathic pain related to multiple sclerosis. Sometimes it's harder to figure out, or due to another condition. And so there are guidelines for the diagnosis of fibromyalgia. I think they've been updated fairly recently to make it a little bit easier to sort out. But it is helpful, if you think that's what's going on, to talk to your family doctor about it, and they may be able to either make the diagnosis or deal with that in terms of an appropriate referral or with the neurologist who's managing your MS, so that there can be a global plan to manage all of your symptoms with a clear idea of what all the different providers you're seeing are working toward in terms of your treatment goals.
Okay, fair enough. Thank you.
Thank you, Susan, for your question. Now on to question number 2 from caller
Yes, the next question is from Karen in Vancouver. Karen, please go ahead.
Hi, I have a question about the relationship between epilepsy and multiple sclerosis. And I suppose maybe the varying types of seizures that people might have. I know I'm not supposed to make it, about myself, but for instance, I do suffer some seizures, not physical ones, but more kind of mental ones. And I'm just curious about how that relationship with MS is thought of.
So epileptic seizures, where people have, alterations in consciousness and their whole variety of features, so where people may have jerking movements and drop to the ground and so on, do appear to occur more often in people with multiple sclerosis than the general population, as I had said. And there have been a number of studies that have looked at that over time. And so there are a number of different relationships that we can see. So there's some people that have epilepsy before they get multiple sclerosis, and they're probably in a way that's unrelated, just happening to have two different conditions that co-occur. There are some people with MS where a seizure can be their first symptom, and some in whom it develops later, which is the most common situation. And we think most of the time that's a consequence of injury from a lesion or a plaque of multiple sclerosis in a sensitive area of the brain that makes it more prone to seizures. And you're right that seizures can vary from individual to individual, and that probably partly relates to where the lesion is that's causing the problem. Fortunately, the papers and studies that have looked at this suggest that in most people with multiple sclerosis, it is possible to get the seizures under control if they are occurring because of multiple sclerosis.
Great, thank you. This was a fascinating presentation. Very interested to see the research that comes from this.
Great, thank you. Dr. Marrie, we do have another question, and this was pre-submitted, and that is, if you were to treat one of the comorbid conditions, could this potentially decrease the MS severity?
So that's a really good question. So I don't know the answer to that yet, but that is one of the reasons I'm really interested in this area, is trying to find out if that's the case. And that's because in other chronic diseases, we're starting to see with things like diabetes and so on, that if we get better control of the other conditions, we can help minimize some of the problems. And so that is ultimately what I would like to figure out, is whether we should be targeting the coexisting conditions as much or more as the MS to try and improve how people with MS feel overall in terms of relapses and disability progression and symptoms and quality of life.
Thank you. Thank you, Dr. Marrie, and thank you to everyone who submitted questions both online and over the phone. At the end of all the presentations, Dr. Marrie is available. We will be having a general question period, and if your answer, or if you were in queue, or if you have another question, you may have the opportunity later on to ask Dr. Marrie. Now we will move on to our second presentation. Now, with MS, we know the body attacks itself and that the immune system may not function properly. However, there are many cells and processes that are involved. The complexity of MS emphasizes the need for research to be done in this area to determine how MS develops and which cells drive progression of disease. Our next presenter is Dr. Amit Barar, and he has spent much of his career determining the role of the immune system in multiple sclerosis. Just last month, Dr. Barar and his collaborators published an article reporting on the immunological changes following bone marrow transplantation as a form of stem cell treatment for patients with aggressive forms of MS. This work is part of a larger Canadian collaborative study funded through the Multiple Sclerosis Scientific Research Foundation. And this project is led by Drs. Mark Friedman and Harold Atkins from the Ottawa Hospital Research Institute. Results of these research show beneficial therapeutic effects of stem cell therapy, and has provided us a clear picture of why these patients have not relapsed following the transplantation. Dr. Barar is also a collaborator on a study co-funded by the MS Society of Canada and the Canadian Institute of Health Research. This study compares MS with other autoimmune diseases to learn more about the mechanisms by which the body attacks itself. Dr. Barar is a neurologist and serves as the director of the Experimental Therapeutics Program and scientific director of the Clinical Research Unit at the Montreal Neurological Institute in McGill. Welcome, Dr. Barar.
Thank you, Karen, and good evening to everyone.
Now, Dr. Barar, you've been a key investigator, as I just mentioned, in a number of MS Society-funded studies. Can you give us some insights that you have gained during your work, and how will it impact people who are living with MS?
Well, I think I've been fortunate to be involved in studies that you'd mentioned, including a new study that involves Dr. Alexander Pratt and Dr. Jen Gomerman to look at roles of particular types of immune cells throughout the spectrum of MS. One of the main things I've learned is the importance of being able to work scientifically in teams. Each one of the teams that were briefly mentioned involve individuals spanning from the clinical world to the basic bench, as well as to clinical trialists, to people who have expertise in imaging of the nervous system. And it turns out that MS, representing such a complex problem, is really best tackled by putting these types of minds together. And what's been very rewarding is the ability to work in such great teams and indeed to make some headway in terms of understanding both causes of MS and, most importantly, gradually, still too slowly for most people, but gradually and steadily translating these insights into better, easier to tolerate, and more effective therapies. I've been charged with a fairly ambitious task of trying to address this title, Risks, Mechanisms of Injury, and Immune Treatments for Multiple Sclerosis. And so rather than delving into details of the work that we've been doing, I'm going to try to use these few minutes to give people a sense of some of the emerging thinking in the MS field in terms of what might cause MS, what might be the actual immune mechanisms that target it, and what might be the therapies and our thinking about how they work. So the first question here is, why is it that some people get multiple sclerosis? And what we do know is that there are a combination of genetic and environmental factors that result in ultimately a state of insufficient regulation of the immune system, and that leads subsequently to the development of injury to self. And so what we've learned is that with respect to the genetics, there are close to 60 genes now identified as contributing to risk in multiple sclerosis, but each one of these really only contributes a very small amount to the risk. And most of these look like they are immune genes, leading to support to the overall view that there are important aspects of the immune system contributing to the development of multiple sclerosis. On the environment side, a couple of things that I will talk about here relate to vitamin D and a particular virus called EpsteinBarr Virus. And what I'd like to do is to discuss these two environmental factors to switch into the question of what we might learn from children with multiple sclerosis. We now know that children can develop MS. You can imagine how challenging it is for a child, for their family and the caregivers in the context of making such a diagnosis and putting together a care plan. We know that in adults with MS, approximately 1 in 20 will have had a first clinical episode that dates back to the pediatric age group of less than 18. So while it's considerably less common to start in childhood, it certainly occurs. And in addition to it itself representing an important clinical need, there's also a very interesting opportunity here, because if you think about it, children who develop MS are on the average that much closer to when this condition must have started. And it provides us with a unique opportunity to ask questions particularly about what in the environment might be relevant. And this is what I'd like to do in terms of identifying, essentially, if you consider at the top the adults and then at the bottom the children, you can see here that the timeline for the children is much narrower, and our opportunity here is to ask about what environmental factors might be contributing to this immune dysregulation and the development of multiple sclerosis. This slide is giving you the example of looking at a virus called the Epstein-Barr virus and essentially asking, if you take blood from these children at the very beginning of their first clinical experience, you follow these children over time to identify who does not have MS and who does have MS, and then you ask along the x-axis here about each one of these viruses. The virus that stands out is Epstein-Barr virus, and the observation is that children who turn out to have MS have a much higher likelihood of having been infected previously with this particular virus, as compared to those children who do not have MS. And this gives us a clue about one of the viruses that we think is contributing to the development of this illness. What about vitamin D? If you measure vitamin D levels in the blood of children at the time that they present with the first clinical episode, and you graph it along this graph, which shows you here the timeline over years, shown here on the x-axis up to 4.5, 5 years, and what you're looking at on the y-axis is that everybody starts, 100% start without yet having the formal diagnosis of MS, and as you follow these children over time, those children who develop a new attack now are known to have multiple sclerosis. If you look at children who have, at the time of their initial visit, levels of vitamin D that are above the normal level, so within the normal range, only very few develop MS within a short period of time, and over years after that, these children with sufficient vitamin levels in their blood do not develop the diagnosis of MS. On the other hand, those children who have insufficient levels of vitamin D at the very beginning of their illness turn out to have, over time, more and more of them developing the diagnosis of multiple sclerosis. And what you see here is the average level of vitamin D in these children at the time of this initial presentation. It's important to note that even in the ones who do not develop MS, this level of 64 is below the Canadian requirements or recommendations for vitamin D. So in general, our society is rather low on vitamin D, and we think this is important, probably for MS, but probably for other conditions as well. Now, as we move on to consider this slide here, which is a very important conceptual slide that tries to help us understand what are the biological causes of the injury to the central nervous system or the CNS of patients. And this is important because if we're going to talk in a moment about therapies, we have to understand what it is that we're trying to target with these therapies. So this is the typical initially relapsing remitting course, as shown here, the RRMS phase, followed by the SPMS phase in the next slide here. What you now see is that when we try to treat patients with MS, we've now got several approved therapies which work for relapsing remitting MS, but as much as we've tried to apply these to the secondary progressive phase, they have not been particularly effective. And the reason we think is depicted in this cartoon down here, where we think that there are at least two different processes that contribute to injury to the central nervous system in patients with MS. The blue biology, if you like, and the red biology. And the blue biology is one which we think represents an important aspect of immune systems getting activated outside of the central nervous system, and like waves, invading and attacking into the central nervous system, causing injury within the central nervous system, and that these waves of immune attacks are what contribute to the development of the relapses and the remissions. And our treatments have been increasingly effective at getting rid of much of this blue biology. On the other hand, the red biology is different. It is represented here by processes taking place within the central nervous system. So treatments given outside may not get into the central nervous system, and the processes may be inflammation, they may be degeneration. This is an area of MS that is under very active investigation because it really represents the most important frontier of understanding the biological contribution of progressive forms of multiple sclerosis. We need to understand this to introduce treatments into this area, and already promising is that the extent of understanding that's been developed in the last 5 to 10 years has contributed to several therapies that are now in advanced phase clinical trials, and we hope to have results from these about potential benefit for progressive forms of MS, both secondary progressive and primary progressive MS, within the next year and 2 years. Now, as we move forward then, we can consider as part of the blue biology, our understanding of what might be contributing to MS is based on the conceptualization that the central nervous system represented on the right side is separated from the immune system by the famous blood-brain barrier. And the next sequence of slides basically indicates that we think activation of immune cells in the periphery, and then their gradual transition, that when we get to the still picture, when it's complete, what you'll be able to see is that we consider there to be a number of steps, very important steps. One slide back here. Very important steps in this cascade. It starts with this activation of immune cells. Then they stick to this blood-brain barrier. They get attracted to it. They invade across it, enter the central nervous system, where they are thought to get reactivated, and that creates the injury to the central nervous system. This is an important conceptualization because it allows us to then think about which one of each of these steps might be the target of therapies, both therapies that we have approved today, but also therapies that are under active investigation. And so we'll be able to look at the slide in a moment again to consider where each of the therapies that we have approved is thought to work. When we classify treatments in multiple sclerosis, both existing ones and future ones, there are many different ways of trying to classify them. This is just one of them, and it shows you a range of treatments that have been considered and tried in multiple sclerosis. They start with what's called antigen-specific. This is based on the assumption that if we knew exactly who the specific bad guys are on the immune system, we could target only them and get rid of them without touching the rest of the immune system to hopefully develop both a safe and effective therapy. Then we have the immune modulators, which target more broadly than the antigen-specific, but can modulate immune responses and try to push them in the right direction. For patients with more aggressive forms of MS, we might consider immune suppressive treatments that say we don't really know everything about who the good guys and bad guys are, but we try to decrease their activity overall. And the most extreme of these is complete immune depletion with bone marrow transplantation. Now, one way of thinking about these treatments is that there's a combination always of consideration of safety on one hand and efficacy on the other hand, and the treatments might be thought of as starting at this end more safe but perhaps not that effective, and as you increasingly raise the efficacy level, you may be doing this at the cost of safety. And this balance between safety and efficacy, of course, is the most important consideration for the teams, the patients, their families to consider in making the most appropriate treatment choice for that individual. And the final slide, I'll very briefly show you again this picture of the full immune system. The previous slide, please. Thank you. This slide here, again, shows you these steps, and what I'll tell you is that the immune modulating therapies in general are thought to change the state of activation or the profile of cells so that they either are less able to get across the barrier, or if they do get in, they're no longer working as bad guys, they might actually be working as good guys. The interferons and copaxone fit that type of profile. When you think about Tysabri or natalizumab, it actually very specifically blocks this step of adhesion and is thought to therefore prevent the bad guys from getting in. Gilenya is a medicine that prevents cells that could be bad guys from even getting out of the lymphatic tissue into the blood. So again, they can't access the target organ. And the most recently approved treatment, Tecfidera, is also thought to modulate immune responses so that they can't work in the CNS. And an important new chapter is understanding how treatments that do get into the CNS might actually be impacting more than just the waves of immune infiltration, but also the neurobiology of MS, the potential to impact progressive disease, and potentially repair, which you'll hear more about from Dr. Jack Antel. And so I will stop here with a summary slide of all the people and all the teams who've contributed to some of the work that I've described to you, and thank you for your attention.
Thank you, Dr. Barar, and thank you for that great overview in terms of treatments. And as you can see from this one slide that Dr. Barar has at the end, all the collaborators from around the world that Dr. Barar works with in order to further understand multiple sclerosis and, more importantly, to try to understand the treatment options that are currently available and potentially developing treatment options for those of us living with multiple sclerosis. We did have a number of questions that came in through email. I will ask you one now, but in the meantime, as I ask you, I want to remind everyone on the line that if you have a question for Dr. Barar, you can enter the queue at this time, and we will take your question after this response. And once again, we do ask you to make the question general and not specific. And we will now proceed to the first question. Dr. Barar, how effective and safe are currently available oral therapies for relapsing remitting multiple sclerosis?
Well, the oral therapies that have been emerging, and particularly Gilenya and most recently Tecfidera, are agents, both of which have been compared to one of the standard injectable immune modulators, and the extent to which they work against limiting new relapses of multiple sclerosis appears to be superior. So here we have oral treatments that are working at least as well and probably better on the average than our traditional injectable immune therapies, although of course there's a range, and this is a discussion of averages, and the challenge is to bring this average information to the level of individual patients. From a safety perspective, overall these treatments are quite effective, but each one of them has certain considerations that need to be discussed in terms of that particular individual person thinking of this treatment with the care team. They are generally viewed as treatments that are far safer than those that suppress the immune system, where large proportions of people might run into problems of insufficient immune response. There are, however, again, a few uncommon low percentage issues that people need to know about and hear about from their caring physician.
Excellent. Thank you, Dr. Barar. I'll turn to the operator. Are there currently any questions on the phone?
Yeah, there currently is one question in queue. The question is from Alex in Toronto. Your line is open. Please go ahead.
Thank you very much, and thank you, doctor, for that wonderful presentation. I have progressive. I am taking aminopyridine. What are your thoughts on this, and what's the future hold for me in your 1 to 2 year trial studies on this?
Well, thanks, Alex. Two very important questions. The first, the 5-aminopyridine. This is an agent that is used in the world of MS and elsewhere. It's an agent that helps with symptomatic treatment. So it's not one of the agents that I previously described that is designed to try to decrease new damage from multiple sclerosis, but it can, for some people, prove to be helpful in terms of their day-to-day function. And it's the kind of medicine, again, to discuss with your caregiver if you're thinking of inquiring about it. And depending on your situation, any other conditions that you may have, any other medicines that you're on, may turn out to be a nice adjunct for you in terms of managing some of your symptoms. With respect to the second question, Alex, the future of treatments for progressive MS, I think that although the timelines are never as short as we'd like them to be, I'm optimistic. I think that the next 2 years will give results at least of 2 or 3 studies looking at treatments trying to decrease the rate of progression in patients who have progressive MS. And if even one of these emerges as successful, it's going to make a huge difference to people who have the type of MS that you're living with. And there are additional medications, probably half a dozen, that are already in phase 2 clinical trials, which means that there are a few more years before we have the final word on them.
Thank you. Thank you so much. Wonderful to hear this.
Thank you.
Thank you, Alex. Thank you for the question. Right now, we do have one question on Facebook, Dr. Barar. This is from Sheralia, and she wants to know, will there ever be a beta-seron pill instead of a shot?
Well, that's a very interesting question. There is indeed work on this. One of the challenges you might imagine is that the immune system sees things very differently if you introduce this medication through the skin or into the muscle, as is the case with the interferon betas, versus ingesting it. And the digestive system can do quite a number on medications and might impact their function. So part of the challenge in translating this has been figuring out how one might deliver the interferon in a way that's much easier for people to tolerate. Certainly, there are a good proportion of people out there who've been on interferons as well as Copaxone for a good number of years. They're tolerating it overall very well, other than the injections. Their MS is kept in reasonable check, and if this could emerge in oral form, which might actually happen in the next year to two, then this would be a welcome addition to many people living with MS.
Great. Thank you, Dr. Barar. And once again, thank you for your presentation and taking the time to answer the questions specifically related to treatment and therapies. I know this is something that is very important to the people living with multiple sclerosis. Once again, everyone, Dr. Barar will be available to potentially take calls at the end of all the sessions. Right now, we are going to move on to a 2-minute break where our operator will put everyone on hold. You will hear music playing during this time. When we return, we will continue with the webinar. Operator, we will now begin our break and be back in 2 minutes. Thank you. Welcome back, everyone. I hope you enjoyed your 2-minute break. During recent years, cognition has become an active area of MS research. Cognitive deficits occur in over 50% of people living with MS, leading to dramatic changes in common tasks such as learning and memory. Our third webinar presenter, Dr. Anthony Feinstein, currently leads an MS Society-funded study involving the development of imaging techniques which better visualize cognitive impairment in MS. This work is critical in determining how cognitive and emotional changes impact people living with MS and could potentially lead to treatment of these symptoms in the future. Dr. Feinstein is a professor of psychiatry at the University of Toronto, as well as an associate scientist at the Sunnybrook Research Institute in Toronto. He also serves as the chair of the Medical Advisory Committee of the MS Society of Canada. Welcome, Dr. Feinstein, and thank you for joining us this evening.
Good. Thank you, Karen, and I'm very happy to be here. So I'm a behavioral scientist, and I research many aspects of multiple sclerosis, depression being one. But I'm not going to talk about depression tonight. I'm actually going to speak about cognitive dysfunction. How common is cognitive dysfunction in MS patients? And that's really going to depend on the sample study. So if you go into the community and look at individuals living fairly independently, the results are reproducible, that approximately 40 to 45% of patients will have cognitive difficulties. For the most part, these patients will have relapsing remitting multiple sclerosis. However, if you collect your data from neurological clinics, MS-based clinics, and if the emphasis shifts to patients with the secondary progressive form of the disease, then the rates of cognitive dysfunction go up quite significantly to 50 to 60% of MS patients. So you can see from these figures that a substantial number of individuals with multiple sclerosis will have cognitive difficulties. Why is this important? So this is not an abstract finding. If someone's got cognitive impairment, then they're much more likely to experience difficulties with work, with their relationships, with many vocational functions. It's even been linked to sexual difficulties, and certainly activities of daily living can also be impacted by cognitive difficulties. So it's important from a clinical perspective that neurologists and neuropsychiatrists and psychologists determine which patients have cognitive difficulties, because as you'll see later in my presentation, there are some treatments that might be able to help. So the next question that's often asked is, well, what are the cognitive deficits that you see in patients with multiple sclerosis? And the hallmark problem is really a reduction in cognitive speed or speed of information processing. So if you think of, MS from a physical perspective, patients with MS might walk slower and take longer to get from, point A to point B. It's the same thing with cognition, that individuals tend to think slower as well. And this is a pivotal point to make, because if you think slower, it becomes much more difficult to do other aspects of cognition as well. You will struggle with multitasking. You will struggle in a work environment where, speed is important, where you have to meet deadlines, where you've got to get things done on time. We live in a society in which, we're very focused on deadlines and productivity and making sure that targets are reached. And in order for you to achieve those kinds of outcomes, you've got to be able to think quickly. And if you have multiple sclerosis, the majority of individuals who are cognitively impaired will experience difficulties with cognitive speed. The information processing will slow down. There's also likely to be difficulties with memory. And, memory is a complex cognitive task. You have to learn things, and once you've learned them, you've got to be able to retrieve them from your memory stores. And the evidence suggests that with respect to multiple sclerosis, the difficulties are with learning new information, acquiring new information. But once you actually are able to learn that information, you can then give it back. In addition, there are problems with abstract thinking, to think outside the box. One example of that is if you give a person a proverb to interpret, they might have difficulty interpreting it because they think in a very concrete fashion. So the ability to think in the abstract might be impaired as well. And then attention and vigilance can be impaired. So you have difficulty focusing on a topic, and vigilance really, by definition, implies sustained attention, your ability to keep your attention going for a prolonged period of time. And that, of course, is very important with respect to the work that we do as well. That if your attention lacks focus, if you can't maintain focus, it becomes very difficult to get the task done. And you can see that if you're thinking more slowly, and this combines with the distractibility, then you're likely to get into all sorts of difficulties when you come to solve problems. So you can see that from this very brief description of cognition, multiple aspects of a person's intellect may be affected by multiple sclerosis. Interestingly enough, language is largely spared. So patients with MS are able to express themselves generally very well. They can find their words adequately, not always, but they certainly can find the words to express their difficulties. So the main problem is not with language. So the work that we are doing right now is trying to determine what's going on in the brain when individuals with multiple sclerosis develop cognitive difficulties. And MRI has been particularly useful in this regard. And we can use MRI in two main ways. The first is to look at structural abnormalities in the brain. In other words, to look at the anatomy of the brain, to try and look at the lesion volume, to see whether the brain has shrunk over time, that's atrophy. And this is some of the work that we're doing now. So just let me show you some brain pictures. So you can see these are brain MRI images in which various departments of the brain are colored differently. You can see in front of you in a particular cartoon that the yellow area refers to cerebrospinal fluid within the ventricles of the brain. The blue areas on the outside refer to the cortex or the gray matter. In between the two, you can see a gray substance. This refers to the white matter. And there are now some very sophisticated computer algorithms that actually separate out the various compartments of the brain for us automatically. So we get the MRI image, we run it through the computer, and the computer separates it out into gray matter, into white matter, into cerebrospinal fluid. It can actually separate out the lesions for us as well. But we can take the analysis to another level of complexity. And here we see a brain divided up into various anatomical regions. Each one is coded by a different color. And what we're able now to determine is that in each one of these specific anatomical locations, we can quantify brain lesion volume, white matter volume, gray matter volume, cerebrospinal fluid volume. And from that, we start looking at correlations between these brain changes and various aspects of cognition. And what we've been able to show is that of all the brain indices that we measure, cerebral shrinkage or atrophy is the most powerful predictor of cognitive difficulties. Should the brain start decreasing in size, as it can do in multiple sclerosis, this can be a worrying development with respect to a person's cognition. This is the other way that we can use magnetic resonance imaging. This refers to functional MRI, and here we can actually measure and look at the way the brain is functioning when patients are trying to solve a particular cognitive task. And I'll show you what this looks like. And these are patterns of brain activation when individuals have to solve a cognitive task. And this is what you see in healthy individuals, individuals without multiple sclerosis. Each one of these particular cartoons refers to a brain slice. And if you have a look at the areas of yellow and red, this refers to parts of the brain that are activating when this group of healthy controls are solving a particular cognitive problem. In the next cartoon, I'll show you what the brain looks like when MS patients try and solve that particular problem. And you can see that there are multiple areas of increased activation that you didn't see in the healthy controls. So the brain is trying to work overtime to solve this particular problem. And this is not an efficient mechanism. The brain is struggling to keep up and having to bring in other anatomical areas and to use more energy to solve this particular problem. Let me just go back one slide so you can see what it's like in healthy controls. And this is what it looks like in patients with multiple sclerosis. And what this means is that should an individual have to multitask, for example, solve things simultaneously, a person with multiple sclerosis will have less cerebral resources, less intellectual resources devoted to all these particular problems. They kind of use up their brain power when it comes to cognitive factors. What this also indicates is something called cerebral plasticity. In other words, the ability of the brain to modify its functioning in order to overcome disability. And the brain is actually quite good at doing this. But in certain individuals, plasticity starts breaking down, and that's when you start seeing cognitive difficulties. So the final point that I'd like to address in this brief presentation is what can be done to help individuals with cognitive difficulties. And there are a number of approaches. We know that compensatory strategies can be quite effective. And the principles behind this is to maximize an individual's residual cognitive strength. So there might be some problems intellectually, but there are also going to be some residual strength that the person has. And so through practice and through routine and structure, you can actually get a person to manage far better in terms of their day-to-day functioning. And these are very simple interventions that one can put into practice in one's clinical work. What's a little more complex are remedial strategies. And remedial strategies refers to the ability to get the brain to improve functioning. Can you, in fact, get an individual to become better at a memory task, or to improve the speed with which they think, or to improve their problem-solving abilities? This is far more labor-intensive from a therapy point of view. There are computer-based techniques that are now being used to try and enhance this. And what's interesting is that individuals who start off with a good, what we call enriched cognitive state, in other words, individuals who prior to the onset of multiple sclerosis, who had led an active life, an intellectually rich life, who had a number of cognitive strengths, these are the kind of individuals who can respond very well to remedial strategies and, in theory, offset some of the cognitive difficulties associated with multiple sclerosis. Finally, there are a couple of interesting new developments with respect to treatment. There's evidence to suggest that exercise now can be effective in helping individuals improve cognitive abilities. Aerobic exercise and resistance training exercise can be helpful. We're not speaking about, hours and hours of exercise. 20 minutes 3 times a week might be all that's required to help an individual improve their cognitive difficulties. And of note, and this is really quite intriguing, that individuals who exercise may indeed show an increase in their brain size, which correlates with an improvement in their cognition. So exercise in moderation can be good for you. And what about medications? There's a little bit of evidence to suggest that one of the drugs, amphetamines, might actually speed up some individual's ability to think, and it might have some cognitive benefits as well. There's also a little bit of evidence, not particularly strong, that the disease-modifying drugs might be somewhat protective when it comes to cognitive problems. In other words, if you're on treatment early on, it might offset some of the cognitive difficulties that could develop down the road. So, I'd like to acknowledge the individuals who work with me and the MS Society of Canada that funds my research. Thank you.
Thank you, Dr. Feinstein, for doing a great overview of a very important topic relating to cognition and multiple sclerosis. I will now ask a few of the pre-submitted questions. And once again, as we ask the questions, callers, you are again invited to enter into queue to ask questions related to cognition and to Dr. Feinstein's research. First of all, Dr. Feinstein, we had mentioned that you're a neuropsychiatrist. We have a question here from Karen from Surrey, BC. She says, what types of therapies or medical specialists can be of help to a person with MS who is experiencing cognitive deficits?
Okay, so thank you. It's an important question. As I mentioned, there are some medications that might give modest benefits. There's evidence to suggest that amphetamines, in particular a drug called L-amphetamine, might help improve cognition. A couple studies have shown this, so this is reproducible data. The disease-modifying drugs, as I've mentioned earlier, might be somewhat protective with respect to certain cognitive difficulties. But it needs to be said that medication per se is probably not the most rewarding area when it comes to dealing with cognitive problems. What can be more effective, and this is something that's certainly within the capabilities of all medical practitioners, is to assist patients with compensatory strategies, boosting an individual's residual strength. Practice, repetition, structure can be very good for an individual. So I'll give you a practical example. If you're forgetful and you don't know where you place the keys in relation to the front door or the car, you have such a structure in your house that the keys are always put in the same place. There's always a little bowl just by the front door where the keys are put when you go out and come in. You can kind of structure things in your kitchen in such a way that you don't end up spending a lot of time looking for cooking utensils. These are very simple instructions that a person can benefit from. What we often recommend is that patients buy electronic devices that they can use as an aide-memoire, so they can strap it to their belt, and they program it the night before they go to sleep and reminds them to do tasks the following day. And they bring their partner in to help them program the particular device. And the device rings before they have to do a task. In a sense, kind of boosting the memory with a compensatory strategy like this. And this is really simple, common sense stuff that can be quite effective. In terms of the cognitive remediation, the ability to actually improve memory or to improve problem solving, that's a much more specialist type intervention. There are not many centers who offer this kind of therapy, but there's emerging data to suggest that this particular kind of treatment, if you have access to it, can be helpful as well.
Thank you, Dr. Feinstein. Operator, do we have anyone on the line in terms of questions?
Yes, we do. We have two questions online. The first is from Karen in Vancouver. Your line is open. Please go ahead.
Hi, I think you've actually already answered my question. I was looking for the name of the drug, and I believe you said it was L-amphetamine?
An amphetamine, that's right. So there are various kinds of amphetamines, various isomers, an L, the letter L before it, L-amphetamine. There are a couple studies, reproducible, showing that this might have some modest benefit with respect to cognition. But you would need a doctor to prescribe it.
Right. The other question I had is, I want to know about access to have an MRI that would actually be able to show what was shown on the slide, where it could, kind of separate out the various areas to see how perhaps the brain size is affecting the cognition.
The images that I showed you there come from research, and those kind of analyses are not done routinely in clinical practice. That said, neuroradiologists are very good at determining whether the brain has shrunk, in other words, whether there's atrophy present or not. And so one can get a very good clinical reading from an experienced neuroradiologist. But the kind of pictures that I showed you, the degree to which we can divide out or parcellate the brain, for the time being, this is usually confined to research practice. My hope is that down the road, as these algorithms work their way into general practice, we're going to be able to start using them clinically, but not quite there yet. The functional MRI pictures that I showed you, where you can actually see the brain working as it tries to solve a problem, this right now is primarily within the research domain, but it's been enormously helpful in increasing our understanding of how the brain works in multiple sclerosis.
Great. Thank you, Karen.
Thank you. And
the caller operator, is there another caller?
Yes, there is. There's a question from Susan in Toronto. Susan, your line is open. Please go ahead.
Yes, good evening, Dr. Feinstein. I've been to your office actually twice. You have seen me on 2 or 3 occasions. And the last time I was in your office, I remember you asking me if I would be interested in participating, and I believe it was the study that you've discussed here this evening. And I was wondering, I never got any results to the testing that was done. You know, you asked if I would be interested in participating in an MRI, and I said I was. And just curious, now that you're here for this teleconference talk, if it would be possible to find out what the results of my MRI was during that.
Well, I would be delighted. I would be delighted to give you the results of the MRI, not on the webinar, of course. And in fact, we can give you a CD with the images as well that you can show your neurologist. And please contact me at my Sunnybrook office. We can meet and go through the cognitive results. And when I see you again, we'll give you a CD with your brain images, and I'll explain what they mean.
Excellent. Thank you so very much, Dr. Feinstein.
My pleasure. Thank you for taking part in the study. It's very much appreciated.
Yes, it was my pleasure. Thank you. I definitely will call.
Thank you, Susan. And thank you to all our participants who participate in clinical trials and trials similar to the one like Dr. Feinstein, because it is important that you do participate in these trials so we can better understand what is going on in terms of multiple sclerosis. Are there any questions? Any other callers on the line?
Yes, there is one further question from Anne in Edmonton. Anne, your line is open. Please go ahead.
Hi, I have a question about the computer-based programs to help with cognitive deficits. Are those like mind puzzles and things like that to help working memory and things of that nature? And would those be something that, you know, they could download like as an app on their telephone, or would it have to be a specific computer program?
My prediction is that that's still coming, that the kinds of programs that are used for, we call it cognitive remediation, they're not yet within the public domain, but they will be there. You know, programs like Lumosity, etc., which have become very popular, you know, I think they're certainly, you know, good to do, and, you know, they're a little bit like doing your cognitive exercise. There's no hard data to show that that's necessarily going to make your cognition any better. The kinds of studies that I was referring to are different kinds of targeted programs looking at very specific aspects of cognition. Memory, for example, problem solving. And there's a little bit of evidence, so there's this, you know, this is slightly controversial. There's a little bit of emerging evidence that targeted approaches might be able to bring about some improvement in memory and problem solving. To date, there are no studies that yet show an improvement in speed of thinking, information processing speed, but there are a number of studies underway specifically looking at this. And so the individuals who are working full-time on cognitive remediation are actually fairly optimistic that these kinds of programs that they're developing can bring about improvement in a person's cognitive abilities. The challenge is going to be to make these interventions more widely available to MS patients, because right now they're only available in a few highly specialized centers, and it's very labor-intensive work. But it's my prediction that this is going to become something more freely available.
Great. Thank you.
Thank you, Anne, for your question. Thank you, Dr. Feinstein, for your great presentation. We are going to move on to our fourth and final presentation, but once again, Dr. Feinstein is available during our Q&A question at the end of the session. Now, the final webinar presentation will be from Dr. Jack Antel. Dr. Antel is one of the most well-known researchers in the global MS scientific community. He's based out of the Montreal Neurological Institute at McGill. Dr. Antel coordinates the Multiple Sclerosis Research and Treatment Program, where he leads research in the fundamental area of myelin repair. Understanding the mechanisms by which myelin is damaged and repaired in MS can lead to the development of appropriate therapies that may help boost repair processes in the central nervous system. Dr. Antel also serves as the National Scientific Director of the NMS Research and Training Network. This network was created by the MS Society of Canada and the MS Scientific Research Foundation. The network is a nationwide initiative formed to accelerate discovery in the field of MS in Canada. Through innovative education and funding programs, the network continues to successfully fulfill its objective of training, attracting, and recruiting MS researchers while increasing Canada's capacity for research in areas of greatest priority. We are excited to have Dr. Antel here to discuss the latest research advancements in remyelination. Welcome, Dr. Antel, and thank you for volunteering to take part in this webinar on such a short notice.
Thank you, Karen. It's my pleasure.
Now, quickly, Dr. Antel, you play a very significant role in overseeing the NMS Research and Training Network. Can you explain how the network has changed the landscape of MS research in Canada, and where do you see MS research in the next 10 years?
So I'm delighted to respond to that because now that we've been doing this for a number of years, we start to see the feedback from what we had hoped would come of mobilizing a larger community of individuals who might be interested in MS research, both clinical, basic science, and by having these people interact with each other and expose them to structured programs, they become aware of what opportunities exist, and they're presented with the challenges of MS, so they'll devote their time to finding the answers. So we now have a community, a larger community, who's moving forward, and I think that the rewards for doing this will become apparent, already apparent by the new people who've entered the MS field. And they will take advantage of all the tools that they bring so that we move forward. And so, again, we've got rewards so far, and we'll have many more as we go forward.
Thank you, Jack. If you now can proceed on with your presentation, that would be greatly appreciated.
Thank you. So I would like to share with you in the next few minutes a real challenge in the field of multiple sclerosis that was already alluded to by my colleague and friend Amit Barar, and that is, and it very much fits in with all of us who are dealing with the clinical aspects of MS, and can the damage be repaired? And I'll just move on to the next slide, and you've seen a slide similar to this one from Amit, where what I'm showing you is the natural history of multiple sclerosis, where on the bottom line is the time of the disease development in years, and shown on the vertical axis is the disability. And what I've numbered for you is the 1, 2, and 3, and Amit spoke to you about the number 1, which is the relapses of the disease, and that when people have new neurologic symptoms. Number 2 is is the recovery from a relapse. Why, in fact, do you get over from a relapse, and what is the importance of tissue repair in contributing to this? And number 3 shown here is what you've been hearing as progressive MS, and one of the major challenges, in my opinion, and I think widely of the MS research community, is in thinking of this progression. Is there continued injury, as Amit was discussing, or if not, as in number 2, if there are repair mechanisms going on, maybe one of the major features of why we progress is there's a failure to maintain the repair mechanisms or to continue to bring them into play. And thus, I would like to talk to you about what are some of the repair mechanisms. And the one that I want to focus on, although there are multiple, is what is the role of remyelination as a repair. Now, on these slides that I have, on one of the this panel, which I marked D, this area, which is the grayish area, or should say that the dark blue area is normal myelin. The area marked D is areas that are totally demyelinated, so loss of myelin, again, the characteristic target in multiple sclerosis. Now, if we look at this panel, which I have the R, you can see that there is an area that is lighter than the dark blue, but is more strongly immunostained or stained than in this D area. And the pathologist can recognize that this is an area where remyelination has occurred. And so there's now very clear evidence that remyelination can occur in the central nervous system and in and around lesions of multiple sclerosis. If remyelination occurs, then we have to say, well, what cells are responsible for mediating the myelination? And there we can take advantage of our basic science colleagues, where they have studied how myelination occurs in the first place in the developing nervous system, and they can even study it in animal systems where they can induce injury, and I'll return to this. And what is apparent is that, as far as all of the basic biologists can tell, that the cells that are responsible for myelination are what we call progenitor cells. So these are cells that are rather immature cells, and then with appropriate signals, they develop into mature myelinating cells that then carry out their function. On this, where I'm showing you here, is actually the work of our colleague who worked here, Chao-Ling Qiu, who we actually isolate progenitor cells and mature oligodendrocytes from the adult human brain. Again, work supported by the MS Society. This is from surgical tissue. This is not from MS cases, but this is part of other surgical case material that has to be resected. And what this slide is showing you, again, from the human brain, it's the cells that are what we call the progenitor cells that more can wrap around nerve fibers and myelinate them than the previously mature oligodendrocytes. So now we focus in on these progenitor cells and try and understand what their capacity is. If we go to the, again, this is work that we've conducted with a wonderful neuropathologist now based in Germany, Tanya Kuhlmann, who worked with us here in Montreal for a number of years, and that with Tanya's efforts, one can now identify mature oligodendrocytes in the brain, and one can identify that there actually are progenitor cells even present in not only in normal brain, but in lesions of multiple sclerosis. So there actually are these progenitor cells present, and if one does appropriate immunostaining, you can show that in early MS lesions that you find cells, are progenitor cells that are being activated and presumably are capable of taking place in the repair process. If you look later in the lesion, you see many fewer of these cells, raising the issue again, as I'll have mentioned and will return to, as whether some of these cells have been injured during the MS process or they're in an environment that doesn't allow them to carry out their work. So why does repair fail in multiple sclerosis? That the progenitor cells were there, as I've mentioned to you. There's all sorts of, we have evidence from examining the brain of MS cases, and including, this is a slide given to me by my colleague Doug Arnold, where serially looking at the lesions of MS after acute injury, after an acute lesion, that the green signal here, when he compares a very specific MR-type study called magnetization transfer imaging, that there are areas where even by imaging you can see that the myelin is repairing itself. So why doesn't the myelin continue to repair itself, and perhaps how does this fit with progressive disease? So one of the postulates is that there's initial and repeated ongoing injury of progenitor cells, and in work that will shortly be published and supported by the Society, we have been able to show, indeed, that the progenitor cells, again working with human cells, that these cells indeed themselves may be subject to injury during the course of MS, and thus many of the therapies we're now using to decrease the inflammation and the injury process, in fact, may have long-term benefits because they may allow the progenitor cells to continue to function or function better than they otherwise would. Another major area is that if the progenitor cells are present, why don't they function? And in any number of studies, both from within Canada and outside, it has been shown that these progenitor cells receive signals from their environment that are required for them to move into the site of injury and also to become activated. And so a major area of research is to find what are the signals that are promoting the function of these cells, and also important, there may be, as part of the scar formation in MS, negative signals that stop these cells from functioning. And already there are many publications in the basic science literature about being able to use signals to promote remyelination and also to get rid of the negative signals. And now we're on the verge of the translation of this into multiple sclerosis, particularly as we have the imaging tools to see that we've actually accomplished what we're looking for. We have to be realistic because, as shown in this slide, here is one of the cells that of the myelin-forming cells that can reach out and could myelinate this axon, which is, you may see it in green. But if the axon is damaged, then the remyelination strategy isn't going to work since there's nothing to remyelinate. So we have to use a collective approach of both protecting the axons from undergoing injury. If we can maintain them, then we potentially can promote the repair, and whether that will be combined with reducing the injury, as Amit was discussing, holds the promise of a combined approach to prevent progressive MS and perhaps deal with it even if it does develop. And at that point, I'll stop, and although I don't have a formal list, I do want to thank all of the colleagues I've had over the years who've contributed to this work. So thank you very much.
Thank you, Dr. Antel, and thank you for giving a very good overview about repair and remyelination, as that is a very important topic when it comes to treatment potential for multiple sclerosis. Now, once again, I do have some questions that had come in earlier in advance. And once again, we invite callers to call in and queue in to ask any questions for Dr. Antel, specifically on his research. Now, first of all, Dr. Antel, we do have a question from Yoon Yan in Calgary, Alberta. She asks, what is the time frame for nerve repair to occur after injury? And she wants to know, how much repair would lead to the improvement in nerve function?
So again, an excellent question. And in fact, from the animal systems, one can see that the remyelination and the repair starts within very, very quickly after the injury. And even the imaging in multiple sclerosis is showing so far, again, that most of the repair is actually initiated very quickly. In fact, that in acute lesions, you can see both injury and repair ongoing at the same time. And one of the challenges, some of the molecules that are involved in inflammation that we're trying to get rid of, some of them may actually be the same molecules that support repair. Now, our challenge is, it looks like if you let the lesions go on very long, over a long period of time, repair becomes less effective. And so one of the issues is that we have to consider is we don't consider that in the one phase of MS we use the current drugs and the anti-inflammatory drugs, and we hold back our repair-promoting drugs till much later on. The answer to your question is that the best repair is occurring early, and so we may have to figure out how to intervene early.
Excellent. Thank you, Dr. Antel. Now, operator, do we have a queue of questions for Dr. Antel?
At this moment, there are no questions. As a reminder, ladies and gentlemen, if you do have a question on the phone, you may press *1 to queue.
Okay, thank you. We do have some other pre-submitted questions, Dr. Antel. One of them is from Wendy in Saskatchewan. She asks, is there a way to repair the nerve damage that is already physically apparent, or at least slow down the process of damage?
So when we're talking about nerve damage, we should divide it into several components. So the nerve itself, which is called the axon, that is the actual structure that carries out the electrical conduction. Now, wrapping around the axon is the myelin, which is the insulation around the nerve fiber and allows the axon to carry out its electrical properties and thus function much more efficiently. If you take away the myelin, the axon and the nerve cell is working much harder, And probably one of the reasons for ongoing progression and late degeneration is just metabolic exhaustion of this nerve fiber that's working so hard. So that the strategy would be, can we in fact work on helping the axon be more efficient and help with its intrinsic properties and perhaps help with its energy supply, while we also try and restore the myelin, which provides support for the axon.
Thank you, Dr. Antel. There is one more question. It's almost like a follow-up to that question, and this is from Sherry from Milton, Ontario, and she wants to know, are there any clinical trials currently that are being done to observe myelin repair?
So, in fact, there are trials ongoing with one or more agents. The challenge is that how would you carry out the trials? And what would you do so that you can most rapidly pick up the effect? So as I mentioned, one of the issues would be that over the very short run, that could you add an agent that promotes repair, and could you say that a person recovers from an attack more quickly? That actually is a difficult study to do clinically because there's so much variation in recovery. The imaging that I mentioned, now that we have tools that could measure amount of remyelination, this may allow us to do that. Now, more dramatic would be, should we go for what I think many of you would regard as the home run? Could we restore function when function has been lost? And there, one of the very clever approaches, for example, would be to select some function that you could measure relatively easily. Perhaps the easiest one is vision. And so that if you took people who had a prolonged period of time where they weren't seeing, and that would be another way of testing out the products. So I think we have potentially the vehicles or methods to test. The more short-term evaluation is ongoing in some clinical trials. There I am aware of one or more approaches that are about to be launched to take on the bigger issue of could you restore a function, and the one that many are focusing on is vision.
Excellent. Thank you, Dr. Antel. And once again, Dr. Antel is available now for a general Q&A. So this concludes all our presentations from the panel. We will now move on to the question and answer session and welcome all participants to submit any questions regarding MS research that was not addressed earlier. We also ask that you keep your questions general in nature. The panel will not be able to discuss issues about your personal medical condition. Now, at this time, we did receive some questions via Twitter, and one specifically came from Jason over Twitter. And this question I'm actually going to direct to Dr. Amit Barar. Dr. Barar, Jason wants to know, his wife has a lesion within her spinal cord, but doctors are not willing to call it MS. Can you provide any insights into this?
Yes, Jason. So when a person has a single lesion confined to the spinal cord, it may represent the first episode of multiple sclerosis, but the MRI obtained at the time of that initial event, and particularly the MRI of the brain, can be very helpful in giving a sense of the risk of ending up with a diagnosis of MS or not. And in fact, if there is one area involved in the spinal cord and nothing at all in the brain MRI, the likelihood of ending up with a diagnosis of multiple sclerosis, even over many years, is actually rather small. It's probably in the order of 5% or less. The other thing to consider is to discuss with the team the characteristics of that spinal cord involvement, because MS is not the only condition that can cause a problem restricted to the spinal cord, and it remains important to make sure that people have looked at the other possibilities in addition to multiple sclerosis. But it does represent one of those situations where an initial episode of neurological dysfunction is shown to be associated with a single area of involvement in the nervous system, and one cannot really make the diagnosis at that time.
Thank you, Dr. Barar. We do have another question, and this comes from Pat. And I would like to direct this to Dr. Ruth Ann Marrie. And Pat wants to know, Dr. Marrie, is it possible to come down with MS at the age of 66?
So that's a good question. So people most often, when they think of multiple sclerosis, think of people who are young adults, because we most commonly see people with their first symptoms beginning between age 20 and 40. But that being said, about 5 in every 100 people with MS will have their first symptoms start after the age of 60. And of course, we've heard from Dr. Barar that there are some people who have their first symptoms beginning under the age of 16 years. When we're potentially diagnosing somebody who's a little bit older than average with multiple sclerosis, we just need to be more careful about thinking about other possibilities that may look like multiple sclerosis when we get older. As we know, things like diabetes and high blood pressure and getting older can give abnormalities on a brain MRI that can sometimes confuse us a little bit.
Thank you. Now we have another question, and it comes from Dave, and this is directed to Dr. Feinstein in particular. And Dave wants to know, the activity in different brain areas during problem solving might indicate different problem solving strategies. And he wants to know, is that the case? And if it is the case, are there different strategies in solving other problems? For example, muscle control and so on.
Okay, so good question. And when I showed the functional MRI data, it's important to realize that these are group data. They don't come from just one patient. It's a collection of patients, and the findings are then averaged out. Usually the sample size is 18, 20, or above. So what you see over there is an averaging out across a group of individuals. From person to person, there may indeed be slightly different strategies, and the brain from one person to another is unlikely to activate in exactly the same way. Also to remember that the brain is actually very plastic. So, for example, in the individual with multiple sclerosis who might be struggling to solve a particular problem, what the brain will do is activate additional areas, ancillary areas, to try and help in terms of problem solving. Or indeed, the brain may activate more intensely in the areas that are supposed to activate. It's like the brain kicked into overdrive to try and solve that particular problem. Now, there are limits to this degree of plasticity, but it can certainly be quite effective in offsetting to a degree some of the cognitive problems. So you will see some change of flexibility from person to person, but we do average out the findings when we come to present our data. In terms of muscle function, remember that muscle function is likely to be a lot simpler than cognitive functioning. And so the mechanism is likely to be somewhat simpler in terms of the brain regions that are activated. But once again, you're still going to see the same pattern of plasticity. If a person, for example, has weakness and they're attempting to move a limb, you will see the brain trying to bring in some ancillary areas of activation to offset the weakness. This is neuroplasticity, and the brain can do that within certain parameters.
Thank you, Dr. Feinstein. Now, operator, are there any questions in queue right now?
Yes, there are. There are 3 questions in queue currently. The first question is from Heather in Powell River. Heather, your line is open. Please go ahead.
Hi, Heather.
Hi. I think Doctor, you may have answered my question. I was wondering about any chances that remyelination could be prompted. And you had said that a challenge to carry it out is an issue. So my question then becomes, is there anything being done to figure out how the challenge can be met?
So again, many people are trying to deal with that, in that the starting point usually has been to take a mouse or an animal, and what you can do in an animal system is you can actually destroy the myelin in the central nervous system, usually with a toxin. And then you can measure how rapidly the recovery occurs. And those systems have allowed us to identify both positive signals that can stimulate the myelination, and importantly, that you can see that there's certain negative signals that prevent myelination. Maybe it may even be easier to try and take away the signals that are retarding myelination by interfering with them with things like specific antibodies. The challenge is, as I mentioned, is now if we translate to the humans, how do we know that we're really accomplishing something? And in the animal model systems, most of them, the measures are over a matter of several weeks, so you know your answer. In the human situation, these may be long-term effects. I think by combining taking advantage of our imaging system, this may allow us to screen through agents much more quickly and get an idea of which ones we really want to concentrate on. As you realize, testing out agents in humans is not so simple because we always have to think about the side effects. So if you have an agent that you want to test, how are you going to get it to the brain? So you need to have an agent that can get into, as Amit Barar mentioned, across the blood-brain barrier. And many of these positive stimulants may have effects on other parts of the body. So we really have to consider, for example, one of the first agents that was tested turned out to have a major effect on destroying the appetite in people, one of the growth factors. So we have to consider both the positive potential of an agent and its side effects.
Thank you, Dr. Antel. Can we move on to the second question, operator?
Yes, the next question is from Susan in Toronto. Your line is open. Please go ahead, Susan.
Yes, good evening, Dr. Barar. I have a question in regards to what I heard recently about the 25 patients that went through treatment in Ottawa with bone marrow transplants, where
yes.
all 25 of these patients had their MS reversed. And I was wondering when treatments such as these will be available right across Canada. I'm dealing with a progressive type of MS, and I'm quite anxious to hear more about this type of treatment for myself.
Right. I understand the question, and thank you for asking it because it actually allows for a very important clarification. While the effect of this treatment was really very dramatic, it did not really reverse problems that were part of progressive MS. These were patients who largely were selected on the basis of having very, very active relapsing remitting MS. And the fact that they seemed to be getting worse neurologically over time was not because they had true sort of pure progression, it's because they had attacks that didn't completely get better, so that was the reason why they had this kind of stepwise deterioration. The treatment was very effective at essentially stopping any future relapses for many years, well, at least 8-9 years after in the earliest patients treated. So yes, the most dramatic effect we've seen on essentially halting any evidence of relapses, but this is not a group of people who really had progressive MS of the type that you're describing. And in fact, in other studies that looked at people with progressive MS, this type of approach sadly didn't stop new progression of their MS, and yet is associated with this risk where about 1 in 20 people treated may actually die from the intervention. So the reason that the paper came out recently was not so much to say that this is a treatment for progressive MS, but to say that because it had such a dramatic effect on one important aspect of MS, while being risky, if we knew what the particular thing was that we changed that was relevant to stopping attacks, maybe the next approach to treatment would be to focus on only the bad guys that we identified without having to ablate the rest of the immune system, so that one would end up with a treatment that is as effective, at least at stopping relapses, without having the same risk associated. Unfortunately, this study didn't really address or sort out the challenge of true progressive MS.
Thank you, Dr. Barar, and thank you, Susan, for your question. We will move on. Thank you. We will move on before the third caller. We will move on to a question from Twitter, and this comes from Esther. And this is to all the neurologists, so any one of you can feel free to step up and answer it, which is from someone stuck in limbo for 3 years. What's the typical length of time until a diagnosis is determined? Ruth Ann, do you feel like answering this one?
Sure. So there's actually a lot of variation in the time it takes to diagnose an individual with possible MS. So sometimes someone appears and they have very typical attacks in a short period of time, or a very typical looking MRI, and they can be diagnosed within a few months of the first symptom, or even with our most recent changes in the criteria, sometimes we can actually diagnose somebody at the time of a very first symptom if they have a particular type of appearance on their MRI. But there are some individuals who have symptoms that are either less typical or who have brain MRIs that don't show all of the features that we might expect in multiple sclerosis. And so for those individuals, rather than mislabeling them and committing them to a lifetime of therapy that they might not need or might not be helpful, we may need repeated visits and neurological exams and MRIs to evaluate people. So there still can be a delay. That being said, over time, on average, there's been a really dramatic decrease in the average time to diagnosing someone. So if you were to first have symptoms in the 1970s, for example, the average time to diagnosis was in the 8 to 10 years range. And as we've sort of moved forward in time, people presenting with first symptoms now, on average, may be diagnosed in a year or less.
Great. Thank you, Ruthann, for the answer. Now we can move on to caller number 3.
Thank you. The next question is from Nick in Milton. Your line is open. Please go ahead.
Yes, thank you very much. My question is to Dr. Amit Barar, and I'm just wondering, Dr. Barar, how portable is your current research in MS to patients suffering from transverse myelitis?
Well, another very important question, and relates to the previous question about a lesion in the spinal cord. That's the lesion in the spinal cord is often referred to as a transverse myelitis, depending on its appearance. What we do know over the years is that there is a relationship between people who have inflammation of the spinal cord that is transverse myelitis and the inflammation that affects people living with MS. But we also know that there are some important differences, including in some of the cytokines or immune factors that are produced. And the challenge has been that there have not been as many people with these types of involvement of just the spinal cord to do the same scale clinical trials with the treatments that have been introduced over the years into the field of multiple sclerosis. So we don't really have nearly as good data about how treatments approved for MS that work in MS actually work for transverse myelitis. In many cases of transverse myelitis, people have one episode, and while it can be very disabling and then one is left with symptoms that need symptomatic treatment, there may not be additional attacks. When there are additional attacks, then we consider this a relapsing remitting condition and usually try one of the treatments that's been used in multiple sclerosis with a view of preventing new attacks, that being in addition to treatments for the symptoms. So the simple answer is that much of the research being done in MS may be relevant for individuals who have just transverse myelitis without other features of MS, but one has to be pretty cautious about trying to translate the insights from one area into the other.
Thank you, Dr. Barar.
Thank you.
Thank you. We do have other questions on our end here. One here was specifically for Dr. Feinstein, and it was related to the use of marijuana. So Rachel from Calgary wants to know, what evidence is there on the use of marijuana for neuropathic pain by individuals who do not respond to standard medication?
Okay, so there are two forms of marijuana. There's the kind that you can smoke and ingest, and then there's also the marijuana or cannabis that's made pharmaceutically. And there's a little bit of evidence to suggest that both kinds, in fact, can help pain and might also have some benefits with respect to spasticity. These are not areas that I'm actively involved in with respect to research, but I am intrigued by the effects of marijuana on cognition. And there the situation is different. There's some data coming out to suggest that individuals who smoke cannabis or who ingest cannabis might in fact worsen their cognitive performance. We've got some data from 2 studies to show that, and some unpublished data that will be coming out shortly that basically confirms the results of earlier studies. So I think when it comes to the use of marijuana, one has to, as with any treatment, weigh up the pros and cons. There may indeed be some benefits with respect to pain and spasticity, and if so, that's good, obviously. But individuals who take cannabis should also be aware that there may be a downside to its use, and in multiple sclerosis is evidence to suggest that may worsen cognitive difficulties that are already present. There's also some good data to show that heavy use of cannabis, daily use, can be quite harmful to a person's mental state and may leave the individual liable to develop a psychotic reaction. So one has to be careful with respect to cannabis. But I've learned to take a non-judgmental approach when I deal with my patients. If someone's got intractable pain and they find that cannabis is helpful, then, this is something that as a physician I have to listen to very carefully. At the same time, I will just inform the patient that they need to be aware that there's some cognitive risks linked to use of this drug.
Thank you, Dr. Feinstein. Operator, are there any other callers on the line?
There are 3 further questions in queue.
Okay, right now we can at least take the first caller in queue.
Thank you. The next question is from Amit in Burlington. Your line is open. Please go ahead.
Hello. I was just wondering, does MS affect certain parts of the brain more than others?
So perhaps, Amit, would you be able to answer that?
Sure. MS, as you probably know, can cause many different types of symptoms, which depend on where in the central nervous system pathways there are lesions that develop. And so lesions can develop essentially in most pathways of the central nervous system, spinal cord and brain. But there are areas that are more commonly involved, and they include the visual pathways, including the optic nerve. So optic neuritis is quite common. They include areas around the ventricular system, which are the fluid-filled spaces of the brain, which might affect people's ability to ambulate and sensation. And they can certainly affect, as we've heard, the spinal cord as well as the structure called the brainstem and the cerebellum, which is responsible for coordination. So quite a range of possible places with a few areas of predilection.
Great. Thank you, Dr. Barar. Thank you, Amit. Can we go to caller 2, operator?
Yes, one moment. The next question is from Wendy in Halifax. Your line is open. Please go ahead.
Yes, good evening. I have a question for any of the neurologists on the panel tonight. I was interested in the discussion of toxins introduced in animal models to cause the demyelination. And I just wondered if any research is currently being done for those like myself who have been exposed to high amounts of chemicals. I understand for specific reasons you can't induce toxins into the human population, but there seems to be enough people out there that a correlated study could be done. I just wondered if that's an area that's being looked at.
Perhaps Dr. Antel, you can answer that question.
I'll try part of it. So the toxins in the animals are very well-defined toxins, and the reason we can identify it is that if you give the toxin to a group of animals, they will all get sick, and a group of animals that haven't gotten that toxin do not get sick. Now, first of all, there is no disease of humans that has been identified where there's been an exposure to a toxin and a group of people got sick in a community. Now, I think your point is well taken that what are the effects of environmental exposures on the nervous system? Now, if the exposure is a very extreme one, then it's easy to identify. If small amounts over a long time or multiple agents acting together are having an effect, that's very difficult to measure, so that we know that MS does not occur in big outbreaks, if you will, as if a whole community suddenly it was exposed to something. Now, what we are doing, and this is where Dr. Marrie can comment, is the people who do epidemiologic studies, who study large communities and large populations, can they tease out whether there are environmental exposures that are contributing factors? For instance, on the genetic side, we now find that there's 100 different genes that contribute a little bit. On the environmental side, are we able to tease out small effects? And I'll leave that to Ruth Ann to comment.
Thanks. So I agree with what Dr. Antel has had to say. It is a complicated question. There are a lot of people working on the question of what the environmental factors might be, and we're getting more sophisticated at figuring it out. One of the challenges, as you might imagine, is trying to figure out what kinds of factors people were exposed to before their MS started. And we have a growing sense that the time when a person presents with their first symptom is not actually when all of the disease processes that Dr. Barar or Dr. Antel have talked about today actually start. So one of our first challenges is to figure out when the clock really started so we can go back and look at what happened before that. And then we need to figure out, as Dr. Antel indicated, how things work together to cause disease in a specific individual. There are a number of very big data sets that are being harnessed around the world now with large groups of individuals who have agreed to provide samples of blood and hair and other tissues who have not had a disease at the time that they provided that material, who then agreed to let researchers ask them questions and get additional information to see what conditions they've later developed, that are beginning to allow us to look at some of those questions. And researchers are increasingly beginning to work together to try and increase the number of people that they have to work with to help us answer those questions. So it's still an area where there's a lot of conflicting information, but I think we're getting smarter about how we're looking at these things, and so we're getting a better idea. And some of those ideas Dr. Barar has already talked about. Vitamin D and EpsteinBarr virus, they're not chemical exposures, but they are environmental exposures that by a lot of people really concentrating on those areas, we're beginning to really understand a lot better.
Great, thank you.
If I can add one final thing, there is an area of research where the basic researchers, as they've been told what potential toxin things in the environment may be doing, they take them back to the basic lab to see whether they can show a mechanism where they could have an effect.
Thank you, Dr. Antel, and thank you, Dr. Marrie. Now, we have reached 8 p.m., which is what we have indicated as the end point of this webinar. I know there are still several people in queue for questions as well. I believe there have some questions that have come through via Facebook. Unfortunately, we aren't able to get to all of the questions today. However, for those people who would like to have their questions potentially answered, we would encourage all of you to go to our website, and we do have an area called MS Answers where you can post your questions, and we will be able to see if we can answer your questions via these neurologists and neuropsychiatrists that have joined us today, or via other medical advisors that we do have aid in our questions and answers in that area of MS Answers. I would like to take this opportunity to thank our presenters this evening. So thank you to Dr. Ruth Ann Marrie, Dr. Amit Barar, Dr. Anthony Feinstein, and Dr. Jack Antel. We also thank all of you as participants in the webinar who are people who are affected by MS or affected by other diseases similar to multiple sclerosis. Thank you also to others who have joined us. They are members of the MS Society, Evelyn Opal Society, members and facilitators of self-help groups, our volunteers, our donors, and participants of our fundraising events like the MS Walk and the MS Bike. We hope you find that the MS webinar insightful. The work that you heard about this evening is only a snapshot of the breadth of research that is being undertaken to improve the lives of people living with MS. This year alone, the MS Society committed to funding over 70 new studies conducted by some of the most highly regarded scientific researchers in the world. We are also committed to exploring and funding all avenues of MS research. Through this effort, we hope to sustain momentum in MS research and ultimately achieve our goal of finding a cure for this complex and often unpredictable disease. We encourage you to visit the MS Society website, www.mssociety.ca, to learn more about the research we are currently funding, as well as the One Day in May website, www.onedayinmay.ca, to find out how you can be part of the campaign. For more information on how you can participate in the MS Society-funded studies, please visit the MS Society MS Research portal at www.msresearch.ca. If you have any comments or questions regarding the information from this evening's webinar, or if you did not have an opportunity to ask the panel the questions, please write to teleconference@mssociety.ca, or you can call 1-800-268-7582. A feedback survey will be made available soon. We'd like to get your comments and suggestions on how we can improve the webinar in the future. Once again, thank you for supporting people affected by MS and the mission of the MS Society, and we do hope you all have a good evening. Thank you.